Okay, I think there's 32 of you on here, so I'm gonna go ahead and start recording and we'll see how this rolls. Okay, so let me see here. Oh, maybe I was recording. I don't know. Well, we'll find out when somebody watches it later on. So, okay, so welcome to our very first NUR 188 Zoom classroom meeting. I do have the chat window up on the side for me. So if anybody has an issue with audio or anything during the thing, go ahead and chat into there and I'll be able to respond to you. What I want to do today is really just go through really the highlights of what we would have hit during our class session related to diabetes, because it really is a big topic. And I just really want to make sure you're getting the key points. I did see everybody did the pre-class prep, was doing the Skylar Hansen VSIM and also the ATI skills module, the diabetes management. Those are all great resources, but a lot of times it's very helpful to talk through the content, to talk through the key points. So I'm actually just going to refer back initially to the class PowerPoint. I am going to go ahead and share my screen, or I'm going to attempt to. So we'll see how this rolls. Okay. So I'm hoping everybody can see my screen on there. So let me just ask you a question right now. Those of you who are looking at my screen, can you see the chat box as well or no? If somebody could just type in the answer, that would be great. You can. Okay. Well, how about I just minimize that? All right. Let me minimize that too. Okay. Okay, we're going to have to do this a slightly different way. Hold on. Let me go back to sharing, but I'm just going to share that one. Okay. All right, so I'm just going back. This is actually just the PowerPoint from the class. I want to go ahead and hit the key pieces of this. First things first, it's really important to understand just normal physiology and just understanding the purpose of insulin in relation to the glucose. The insulin is the mom, and it's taking the glucose, the child, inside the cell, inside the house from the school bus. That really is a very basic understanding of it, but if you get that, it makes sense. It makes sense. And it's also a helpful way to kind of explain it to your patients when you're taking it down to their level, when you're having to explain a very complex disease process. But diabetes is very complex. It's complicated in the sense of how everything balances. So it's important to just kind of understand that piece of what insulin does. And then, of course, what glucagon does. Okay, that's the hormone that basically keeps us from dying from hypoglycemia at night when we're not eating or when we're fasting. Okay, as you know, the liver is going to store unused glucose as glycogen, and that is provided as a source of energy for us. Okay, when we have high levels of glucose in the blood, when you think about the body's natural response, we talk about hyperosmolar dilution. So that is going to be the thing that stimulates your thirst. That's why you want to drink after a glass of milk after you have that nice big piece of chocolate cake. You want to kind of dilute out that glucose. Your kidneys will also try to get rid of that excess glucose as well by just putting it out in your urine. Now, something that's interesting to know, when we talk about a urinalysis and testing a patient's urine to see for the presence of glucose in there, you're not going to start spilling glucose into your urine until your serum glucose is about 180. Okay, so if your patient has glucose in their urine, you can rest assured that their levels are definitely above where they need to be. Okay. Pathophys, just some basics here, understanding that type 1, there is no insulin whatsoever being produced by the pancreas. Therefore, those patients are always going to need insulin, either as an injection, via pump, anything like that, but they are always going to need insulin. Whereas type 2 diabetes, the pancreas is still working, it is still producing insulin, but it's not producing enough insulin. The insulin that it makes is kind of impaired, it's not working effectively. And also the body's cells is a little bit more resistant to that insulin. So there's lots of different things going on with type 2. Now, years ago, we used to talk about how type 1 was insulin dependent and we used to call type 2 non-insulin dependent. That's not so much true anymore. The reality is a type 2 diabetic, if they are uncontrolled or they have had type 2 diabetes for a very, very long time, eventually the pancreas is going to get to the point where it's not able to produce insulin. Okay, so that's why you will see type 2 diabetics who are on insulin therapy. So it's really important to understand with type 2, we can use insulin. With type 1, you cannot use any of the oral anti-diabetic meds or the non-insulin injectables. Okay, type 1 absolutely needs insulin. Looking at your active learning template, if you want to pull that out from your prep, just a couple things I want to kind of comment on. For type 2 diabetes, the biggest risk factor is going to be obesity and being overweight. Now, that doesn't mean 100% of your patients are always going to have that, but that is the #1 risk factor. And therefore, health promotion really focuses on managing an appropriate weight, and also making sure they're getting checkups with their doctor, that they're getting annual blood work, annual screening. Because with type 2 diabetes, it comes on very slowly. It's very insidious. And prior to the time when we started actively doing screenings and doing active blood work every year, patients may have been diabetic or showing some level of glucose impairment for up to 7 to 10 years before an actual diagnosis. So just think about all the damage that took place during that time. That's why that health promotion piece is so important, okay? With the expected findings, as you looked in your books and you were preparing your ALT, you probably heard about the 3 polys: polyuria, polyphagia, polydipsia. Those tend to be a little bit more pronounced in your type 1 diabetes. Basically because your cells are absolutely starving and the fact that your serum glucose levels are just really out of control. You'll see those things also with type 2 diabetes, but they're not as pronounced. They may not be picked up as early. A lot of times your type 2 diabetics, if they're not diagnosed and they're presenting to the hospital, it's usually because they're having a cardiac event. Maybe it's a heart attack, a stroke. Maybe they have a wound that's not healing on their foot, or they come in and they're in chronic kidney failure. Okay, so that damage occurs over time. So sometimes the expected findings for type 2 diabetes are not those huge red flags the way you would see with type 1. Complications, really our big ones are the damage to the kidneys, the nephropathy. Diabetes and hypertension are the top 2 causes of end-stage renal disease requiring dialysis. I mentioned before about cardiac. Okay, so elevated blood sugars do cause damage to the vessels, to the heart, puts them at higher risk for heart attack and stroke. We worry about retinopathy or microscopic damage to the eye blood vessels, eventually leading to blindness. And then, of course, neuropathy, where it damages the nerves, and these patients develop paresthesias, numbness, tingling, pain, and then eventually it gets to the point where they are completely numb. So it's really important to understand those complications, because that's really what treatment is all about, trying to prevent or at least delay, push off those complications. I'm not going to take you into the interactive case study. You guys can take a look at that on your own. There's actually several interactive case studies in relation to diabetes, so I do strongly recommend that you go in and look at those. There are several questions in there, both multiple choice, select all that apply, and there's some short answer items in there. And I would encourage you, as you're doing these, if you haven't done them already, go ahead and do them, but put your textbook, put your ALT, put all your stuff aside and see how you do going through it. If you already did it as part of your prep, close up your stuff and do it again and see how you do. The more exposure you have to this content, the more repetition, the better it's going to go. So with the oral anti-diabetic agents, and if you kind of pull out your worksheet that you had for your prep, I want you to understand that there are many different oral anti-diabetic agents. And the reality is you're not going to be able to memorize every single one. But I do want you to have an understanding of how the 5 basic ways that these agents work. And it's really important to understand that some of these medications work in more than one way. So they might hit 2 or 3 things on this list. But if you understand how the oral anti-diabetic agents work, it makes sense why you cannot use these with your type 1 diabetics. Okay. So these items, they're going to work either by stimulating the pancreas to make more insulin, making the tissue more sensitive to the insulin that's already being produced, slowing the carb digestion and absorption. Okay, so that's helpful because I have a much slower increase of the blood sugar than I would have with a rapid absorption. They might inhibit glucose production by the liver. Okay, that is mostly your metformin, which is your #1 oral anti-diabetic med. And the last thing they do is promote glucose excretion by the kidneys. Some of our newer classifications do this. Okay. Now, the next several slides, I'm just going to tab on through these pretty quick because you have access to these. But glucophage, metformin, we've talked about this one before. Kidney function is really important, particularly the GFR. We know about holding this medication for 48 hours post-IV contrast studies. That's really important. The other ones you can go through and read on the PowerPoint. Obviously, all of them are going to have a potential side effect of hypoglycemia. Anytime we're improving the use of glucose, we have that risk. But the other commonality you see between all of these typically is they can cause some GI symptoms, usually like a GI upset, some nausea, some upset stomach, at least until your patient adjusts to the medication. I'm just going to tab on through these here. You can take a look at those. I do want to stop here for a minute just looking at your non-insulin injectables. This is a newer class that they've come out with probably within the last, I'd say, 5 to 10 years. And this is all about mimicking the natural hormones. But this has actually become a pretty mainstream treatment that our patients are seeing. Some of them are given daily. Victoza is administered daily. A lot of them are given weekly. Trulicity is one that's out there on TV quite a bit. And they do work very well, especially the weekly ones. Trulicity in particular, it comes in an auto injector. So it's not even a pen. They don't even have to put the little needle on the pen. With the auto injector, everything is all contained. And that's a really easy one for self-administration because your patient's going to be doing that at home. The problem with these medications, this particular class, these types, is they are extremely expensive. The drug companies do have what they call voucher or coupon programs that can reduce the cost. However, if a patient is receiving any type of publicly funded insurance, so Medicare, Medicaid, CHIP, things like that, they are not eligible to use those coupons. Again, here's another interactive case study with the diabetes and specifically linking it to the hypertension and coronary artery disease. And although we're not going to get into coronary artery disease specifically during this class, that is more MedSurg 2, I believe, we are going to get into hypertension and we're going to get into stroke. So when we talk about coronary artery disease, yeah, that refers to the heart, but the reality is the same damage is happening up in the vessels in the brain as well. So we're talking cerebrovascular disease. Looking at insulin, you guys have had some experience with that. You've probably all taken care of diabetic patients out in clinical. The biggest things to keep in mind with insulin is that there are different types. And as the nurse, you need to understand what type or types your patient is receiving. And keep in mind that when the insulin is peaking, whatever type it is, when it is peaking, that is the time when your patient is most at risk for a hypoglycemic episode. Okay, so as a nurse, it's important that you understand to recognize signs and symptoms of hypoglycemia and be able to test and respond to it appropriately. Anybody who's taking insulin, and you'll see it on the screen in red there, they should always have a glucose source on hand, a fast-acting glucose source. That's just a must-have. They should also wear a medical alert bracelet that would indicate that they are diabetic and on insulin. That's very helpful to know. The other big piece I want you to know off this slide that's a critical thing is that beta blockers can mask signs of hypoglycemia. Beta blockers are commonly used as a treatment for heart failure, possibly hypertension. So there's a lot of patients out there on beta blockers, and those will mask those classic signs of hypoglycemia. So if you have a patient who is diabetic and they're on a beta blocker, they really do need to check their blood sugar routinely, because they're not going to have those classic signs and symptoms, and they may go from talking to you to being completely out and unresponsive. We'll pop through this. This was kind of covered as part of your prep, but just again, understanding the different types of insulin and their onset, peak, and duration. So I'm going to go ahead and open up, I think, maybe this chat box and just kind of see this NCLEX item. I want to see how you guys are doing with this. So the nurse is teaching a client with type 2 diabetes. They have a new prescription for glimepiride. So which beverage should the patient avoid? Okay, which beverage should they be avoiding? Let me see if I can pull up the chat here. Maybe not. Oh, we definitely don't want to see that, right? Okay, well, I'm gonna take your word for it that you're answering this, but the correct answer is grapefruit juice. It's C. And grapefruit juice actually interferes with the absorption and the effects of various medications, not just this medication, but various ones. So that's kind of a rule of thumb that in general, if patients are on medications, they want to definitely space them away from grapefruit juice. And then there are certain medications where we would just avoid it altogether. All right, so another NCLEX item. Okay, nurses caring for a client with type 1 diabetes. We misread the client's morning blood glucose as 210 instead of 120, and a dose of Novolog was administered incorrectly. So we're looking at what is the priority action by the nurse. Okay, what's the priority action? And if you're approaching this based on NCLEX principles, okay, you think about the nursing process and assessment being the nursing process. So let's just kind of, work our way through here. Give the client 15 to 20 grams of a carbohydrate. Well, do they need that? Is that too much? What else are they having for breakfast? So do we know enough yet that it's appropriate to go ahead and give that? We may end up doing it, but I don't know what their blood sugar is at this point. So I don't know yet if that's okay. All right. Monitoring the client for hypoglycemia. That is totally appropriate because they're definitely at risk for hypoglycemia. I don't necessarily want to respond and give them too much, carbohydrate if it's not necessary. Okay, so that's the one I'm kind of thinking of, but let's keep reading because a principle of test taking is going to be to look at all of your options. Complete the facility incident report. Obviously, we need to do an incident report, but that's not the priority right now. Your priority is always going to be taking care of your patient first. D is immediately notify the provider. And if I'm looking at that, yeah, I want to notify the provider, but does it need to happen immediately? Okay, is that a higher priority than me first assessing and taking care of my patient? Okay, so when you're looking at this, the correct answer is going to be B, monitoring the client for hypoglycemia. Now, obviously, if that would occur, I'm going to go ahead and start treating them per the protocol. And if you recall, treating for hypoglycemia, it's going to depend. Is your patient awake and alert? Are they able to swallow? Okay, versus they're not able to swallow, or they're unresponsive, or just not, they're disoriented to the point that they would not be able to take oral intake. And the dreaded select all that apply. I know you guys love them. When teaching a client with diabetes about reducing the risk of complications, what information should be included? Select all that apply. So again, what are we focusing on? What's the question asking? We're looking about reducing the risk of complications for diabetes. So let's approach this as a true-false situation. So looking at A, would you teach a client with diabetes to keep their cholesterol intake to no more than 200 milligrams per day? And that answer is yes, because they are at risk for cardiac complications. That's going to help reduce that risk. Okay. B, start walking 20 to 30 minutes per day. Yeah, I do want to do that for the cardiovascular benefits. And the other thing that's going to help with that is if they're losing weight. The idea is if they're walking, they're expending more calories than they're taking in, and they start losing weight, that is going to help the cells be more receptive to the insulin that is already being produced by the pancreas. And that's pretty important, because if the studies are showing with even, a 10% weight loss makes a significant difference with improved glucose control. So I would definitely want to do that. Sign up for a smoking cessation program. Absolutely. Okay. Absolutely. Because smoking, well, not just smoking, but nicotine in general causes vasoconstriction and vasospasm. So that's going to decrease circulation to your extremities. We know that wounds, poor circulation is associated with diabetes. Okay. D, aim to keep your blood sugar between 140 and 180 to ensure an adequate glucose supply for your nerve cells. Well, I like the part that says adequate glucose supply for the nerve cells. But if you look at that, 140 to 180 is too high. That's not where we want them consistently. Okay, so that's going to be incorrect because that is too high. And your last option is your goal for blood pressure control is 140 over 90. In general, that is a true statement. For our hypertension patients, that is typically the goal. However, if they have hypertension and they are diabetic, we actually aim for 130 over 80, okay? Because their cardiac risk is so much higher with the diabetes, we want to keep that blood pressure controlled even more, keep it down even more. Okay, you can take a look at the last case study. This revolves renal insufficiency related to diabetes. And again, diabetes and hypertension, the top two causes of chronic kidney disease. Okay, so all of you took a look at the VSIM with Skylar Hansen, and I was reading your responses. A lot of you thought that this VSIM was a little bit different than some of the others that you did, in the sense that he started going downhill fairly quickly and you had to respond pretty fast. So you all worked the simulation and got to where it needed to be for your scores and that. Couple things though I wanted to point out with Skylar. And depending on how you progress through the scenario, how quickly you did certain things, when they initially checked his blood sugar, and I think he was sitting at like 61, which is technically meets the definition of hypoglycemia. And people might think, well, that's not too low. Well, it's below our normal range, and if he doesn't get something in him glucose wise, he is going to continue to drop. And that's part of nursing, is anticipating what is going to happen. It's kind of like a patient who takes Lasix, and we know that that's going to lower their potassium level. Well, I checked their potassium this morning and it's 3.5, so everything's perfect, right? Okay, it's within normal limits now, but what's going to happen when I give that Lasix? It's going to drop further. So kind of the same situation here. Okay, he's at 61 now. Even somebody who's 61 and not symptomatic, you still want to address the hypoglycemia. You still want to treat it, because if we don't, it's going to keep going down. We don't have, a stopgap there. So that's something to really think about. And the thing I wanted to point out with that is how you respond to hypoglycemia. And I mentioned this before, a couple minutes ago. But if your patient has hypoglycemia and they are alert, they are talking to you and they can swallow, we want to treat them with the oral carbs. We want to give them 15 grams of a carb and recheck their blood sugar in 15 minutes. If they're still low, we're going to retreat them with another 15 grams of carbs and check again in 15 minutes. And we're going to follow that process. If it's going to be more than an hour till they have their legitimate meal, you want to give them a carb with a protein to kind of tide them over until they get to that next meal. So that's really important. Now, let's say they're awake, they're oriented, but they can't swallow. They cannot safely swallow. Okay. Or they're disoriented, they definitely can't swallow, or perhaps they're even completely unresponsive. Oral is out of the question at this point because that could pose more harm than good to them. Okay, so at that point, they really need the IM glucagon or they need the IV dextrose. Now, that's all talking in a hospital or facility type environment. Okay. And it's important to understand that when you're in that type of an environment, I want to check their blood sugar. I want to see what it is first before I start treating them. Okay. Because hypoglycemia, those symptoms can also mimic some other things. And if it's not hypoglycemia, I don't unnecessarily want to raise their blood sugar. So if I'm at a location in a facility where I can check their blood sugar first, before I then start loading them up on the carbs or doing the IM glucagon or the 50% dextrose, I want to check that blood sugar. But if you're in a situation where you don't have access to that, you're out in the community, you're at a basketball game, you're just, out walking on the street, you're in Wise, okay? And somebody goes down and we're thinking it's hypoglycemia, we're going to treat first, because the reality is hypoglycemia is going to kill your patient way before hyperglycemia. Okay, so that's a really important point I wanted to emphasize from the VSIM. The other thing that I wanted you to think about in relation to this VSIM is this patient is 18 years old. And that's very different from a lot of your clinical patients you've taken care of, because the reality is most of them are middle adult or older adult. Skylar's a young adult. And I would even hesitate to call him young adult. I would like to call him late adolescent. That late adolescent, early young adult period, there's a lot going on developmentally, okay? They're adjusting to being on their own, trying to establish an independent identity from their parents, kind of taking the reins for themselves. That is a challenge for a healthy teenager, let alone a teenager that has a chronic illness such as type 1 diabetes. And in this scenario, he was just diagnosed 6 months ago. So this is pretty new to him. So when you think about teaching in relation to this patient, there's a lot he needs to be taught, but you have to break it down to his level and to his developmental state. You have to prioritize. What does he need to know first? He absolutely needs to know the signs and symptoms of hypoglycemia and what he should do about it. He needs to know to carry that fast-acting sugar with him all the time. He needs to know how to check his blood glucose so he can monitor that. And because he's type 1, he's going to have insulin, so he needs to know how to administer his insulin. The other stuff is important too. I mean, he needs to know about, getting lab work and following up and the diet and the nutrition. That's all important too. But if you look at the critical points, the life-saving points that he absolutely needs to have, okay, because if you can only teach him 3 to 4 things, what's going to be your priority pieces? Again, looking at an NCLEX item, which action should the nurse take first when developing a teaching plan for a client newly diagnosed with type 2 diabetes? So go back, think about your nursing process. So develop realistic short-term goals for the client. Well, I'm going to do that, but let me see if there's something I'm going to do first. Providing the client with a video about diabetes. Okay, I might do that, but I would need to have my goals first. So I'm going to eliminate that one. Determine what the client knows about diabetes. Okay. Verify that the client is scheduled for follow-up blood work, fasting glucose and the A1C. So those are all things that I'm going to do. But if you think about which one is going to be the first thing that you do that is really kind of going to dictate everything else that you're going to do, it goes back to assessment. And even though option C does not use the word assessment, it doesn't use that term, it is assessment. Think about it. Determine what the client knows about diabetes. Okay, so we are assessing. It's a good place to start. If somebody has at least some baseline knowledge of diabetes, you can check their understanding for accuracy, kind of reinforce that and build from there, versus somebody that has maybe heard the term but has no idea what it means. Okay, which goals should be included when planning a community diabetes management program? Okay, what is the question asking? Okay, which goal? Okay, so understand the difference between goals and interventions. Okay, so when we look at proper foot care will be demonstrated, is that really a goal, or is that an intervention that you're going to actually implement during the teaching? Participants will have a decreased incidence of foot amputations. Okay, that sounds pretty good to me, but let's keep reading. The nurse will reserve a facility to host the program. Well, that's more of an intervention, something I would need to do this program. Handouts and patient level teaching materials will be distributed. Okay, again, that's an intervention. So when you're looking at those, which one is a goal? Remember, goals need to be specific, measurable, and they should have a time frame, which it's not in here, but it would be at the end of, the teaching and following them long term. So your correct answer is going to be B. All right, I want to switch gears here real quick just to kind of go over some items with the group activity. Actually, no, scratch that. This was a group activity we were going to do in class where I was going to divide you up into groups, and we were going to kind of look at different strategies to manage diabetes, and you were going to present to the class. Back here. So a couple things that I want to take a look at with this would be preventing complications. So let's start with cardiovascular complications. We know these patients are going to be at higher risk for both heart attack and stroke. So the number one thing that our patients can do to help reduce that risk is going to be controlling their blood glucose. Beyond that, these patients should be regularly seeing a primary care provider at least twice a year for monitoring of their blood pressure, monitoring of their glucose, and looking at that A1C. If they have the risk factor of hypertension or they have risk factors for hypertension itself, they may require some medications related to that. And we're going to cover hypertension in depth as part of Unit 5. Okay. When you think about kidneys, okay, kidney failure, kidney disease, again, the things that I already talked about are very important, following up with that care provider. We're going to be getting blood work at least every 6 months. But part of that is also going to be getting a urine sample and checking for what we call urine microalbumin, okay? Usually they're going to do that at least once a year. Sometimes they'll do it twice a year, every 6 months. But that is going to be a big indicator of whether we're starting to see some development of kidney impairment. Other things that are important for protecting their kidneys is that they're maintaining hydration, okay? Very, very important, because the kidneys are going to be the ones that are metabolizing and excreting a lot of these substances. So making sure they are well hydrated, things flow through very easily, is going to be important to protecting those nephrons. The other big piece you need to think about is avoiding or limiting nephrotoxic drugs. Okay, and these are drugs that can be damaging to the kidneys if taken in high doses, or if taken in regular doses over a long period of time. And the biggest nephrotoxic medication we think about are going to be your NSAIDs, your ibuprofen, your Aleve, Advil, because they're available over the counter and a lot of people take them. And they're available over the counter, right? So they must be safe. That's something that these patients with diabetes really need to be taught, that they need to watch anything that's going to tax their kidneys. Again, also with the blood work, we're going to be looking at BUN and creatinine and GFR. Kind of moving on down our complications, thinking about retinopathy with the eyes. Not a whole lot you can do there with the exception of really tight glucose control, trying to keep their sugar under control. But these patients should be having a diabetic eye exam with an ophthalmologist every year. Okay, that is part of the standard of care. The last topic I really want to focus on here is going to be protecting your feet. We already talked a little bit about the neuropathy and how that develops. Okay, the glucose actually causes damage to the nerves, and then you get the abnormal firing. So that's where they have that numbness, tingling, paresthesias, and eventually the development of numbness. There's also glucose effects on the vascular system. So it causes hardening of the vessels down there. They don't vasodilate, vasoconstrict as well. So that affects circulation to the extremities. Those two things, plus the fact that they have high levels of glucose in the blood, are going to put these patients at much higher risk for developing foot ulcers. Okay, if they have any type of break in skin integrity, it gives a portal of entry for bacteria to get in there, and the glucose that's in the blood provides a perfect medium for that bacterial growth. And the problem with this is, because of the associated neuropathy, the patient may not even realize something is going on with their foot until you have a massive infection that is set in. And sometimes that infection gets into the bone, and it can result in amputations. So when we think about this, for client teaching, diabetic foot care is a very critical topic that we need to be covering with these patients. They should be washing and drying their feet daily. They don't really want to vigorously rub. They want to pat dry. They want to make sure that it is dry in between their toes. I think I mentioned this before. You can use a hair dryer on cool setting. I can't emphasize that enough. Cool setting to help dry in between the toes. They also need to be taught to look at their feet every day. They need to look for cracks. They need to look for open areas. They need to look for sore areas, corns, calluses, anything like that that can turn into a problem. Okay, if they can't see the bottom of their foot, if they can't bring it up to be able to visualize, get a mirror, set it on the floor. They need to be looking at their feet. They can use lotion on their feet. It is recommended because diabetics do have dry skin. However, they should not be putting lotion in between their toes. That's a very important point. We recommend that these patients wear white socks or light colored socks, because if a problem were to develop and drainage starts coming out of something, they're going to be able to see it on a light colored sock versus a dark navy or a black colored sock. Okay. Wearing shoes, well-fitting shoes all the time is very, very important. Okay, these patients should not be going around barefoot. They really should not even be going around walking just in socks, because there's no protection there for their feet. Okay, so that's really, really important. When it comes to trimming their nails, diabetics can be taught to trim their nails. They should be trimming them straight across, not on an angle down by on the sides, because that would predispose them to an ingrown toenail. If they are trimming their own nails, they should be trimming them straight across, and they recommend using a nail file instead of really using a clipper, because you want to make sure you don't clip them too low. You want to make sure you're not hitting into the skin. So a nail file is what's recommended. Some people don't do their own nail care. Medicare actually covers podiatrist visits every 9 weeks just for toenail trimming. Okay, it's a big issue with the older adults. So that's an option too. If you have a patient who's an older adult, they really should be seeing that. The podiatrist is really the foot specialist, and if they develop any type of wound on there, they really should be seeing podiatry. So that kind of really covers the big key education points. Other things that would be important if you're teaching a patient, they would need to know how to check their own blood glucose. So if you think back to last semester when you guys learned to check blood glucose, if you were teaching that procedure to a patient, what would they need to know? If you're teaching the patient, again, how to identify signs and symptoms of hypoglycemia and how to respond to it, things you would teach the patient. Also, if they are getting insulin or they are going to be getting one of those non-insulin injectable medications, how do they appropriately administer that? Of course, nutrition teaching. Okay, one of the big hallmarks of diabetes is obviously going to be the diet and nutrition. So understanding what a consistent carbohydrate diet means and, you know, how many grams of carbs equal one carb exchange. Okay, that's from Foundations. 15 grams of a carb equals one carb exchange. Okay, that's important for meal planning. So those are all things you want to go back and review and think about it from the perspective of the nurse who is educating the patient. Because the reality is, this is a chronic long-term disease that the patient is going to have to manage with the assistance of the healthcare team, but it's the patient who's driving this. That kind of leads me into CP3. So this is a client teaching plan. It's a video assignment. I know some of you have already looked at the instructions. Some of you have actually already signed up for a topic. So that's cool. I'm glad you did that. But this project is basically focusing on preparing and providing teaching for a client that is newly diagnosed with diabetes. And there's two components. There's a written component, which basically kind of helps you plan out what you're going to do. And then there's the video component where you're actually going to teach the patient. Okay, so there are two separate drop boxes. There's a regular drop box for the written component, and then there is a video drop box. And these are both on the clinical Plato site. And these are due Wednesday, April 22nd by 1630. This is for all students. And this one's going to be 30% of your overall clinical portfolio grade. By this point, you have all interacted with patients on MedSurg. Most of you have been to same day. Those of you who are not physically going to same day, but are doing the same day cases this week, part of your activities involves doing discharge teaching and videoing yourself providing discharge teaching. So by the time you guys get to this assignment, you've all had some experience with this. Resources I want you to think about for this. You don't necessarily need to go out and find things. For this particular assignment, for the written component where you're providing the rationale, I want you to use the resources that you have. For the video component where you're actually teaching the patient, I'm okay if you use resources from WebMD or Lippincott Advisor, but remember, they need to be patient directed at that point because you're providing the teaching. So some resources, definitely your ATI. Your ATI nutrition is a great resource here. Certainly your Hinkle and Cheever, Lippincott Advisor, the up-to-date patient handouts. I listed PCT Nursing Lab for props and equipment. I'm still crossing my fingers that maybe we'll be able to get into the labs by then, but I'm not holding my breath. But the idea is to try to make your teaching as realistic as possible. Now, what I was talking about in the nursing lab for props, we actually have plastic food that's there in appropriate portion sizes. We have nutrition labels. Obviously, we have the glucose monitoring equipment. We have the insulin pens, things like that. But there's other equipment that you can use if you were teaching diabetic foot care. You know, I mean, really, a basin, washcloth, a mirror, socks, shoes, teaching them how to do that. Again, if you're using outside resources, whether you're referring the patient to a particular website, providing them with a handout, if you're referring them to a specific app, maybe on their phone, you're looking for stuff for this assignment that's geared towards the patient, not the provider, because you're providing that teaching. Okay. So I'm going to stop sharing my screen at this point. Oh man, I totally missed that. Okay, I will answer your questions now because I can see your group chat here. Oh, good. See, you were all responding, and I just wasn't able to see any of your responses here, but that's pretty cool. All right, so let me come down here. Okay, the table for the insulins that you show in the PowerPoint is different from the time frames that Hinkle and Cheever. Which one should we follow? Really looking at that, any place you look is going to be slightly off. But kind of looking at this, I'm looking at the basic concept. So for example, if you're giving rapid acting insulin, you're giving Novolog, Humalog, and that's typically the insulin that we are going to use with in sliding scale coverage in the hospital. You don't want to give that too far before the meal, okay? Because you take the risk of dropping them before they're ready to eat because of the onset of how quickly it starts working. So with your rapid acting insulin, if you think about the timing of administration, I want to give it, no more than 5 minutes before the meal, okay? Preferably with the first bite of the meal. If I'm doing regular insulin, which is your short acting insulin, I'm okay to give that about 15 to 30 minutes before the meal, because then it's going to be starting to work when they're eating. Okay. With your regular insulin, when we talk about, your peak, you're going to start seeing that, an hour, 2 hours, sometimes 2.5 hours after that. Again, the key thing with the insulin for the most part is if I'm giving insulin, I need to make sure there is glucose available for it to work on. Okay. So if I'm doing that, I need to make sure my patient can eat. The one exception to that would be with a patient with diabetic ketoacidosis, okay? Diabetic ketoacidosis, or HHNKS, which is the type 2 version, those are situations where the blood sugar is extremely high. And most of the time, that is going to be in relation to an illness, okay? Typically, it's because a patient's ill. When you're sick, when your body is under stress, whether it's physiological stress from an illness or it's psychological stress that we might all be experiencing now with being quarantined, your body's metabolic rate goes up. It needs more glucose. So your body is going to respond. Your liver is going to start breaking down the glycogen into glucose to provide that source. Okay. So in doing that, it's going to raise their blood sugar. So even if you have somebody who's ill, they're not eating, they're not drinking, they're not taking in carbs, their body is still providing a source of glucose. So in a diabetic, if we're not testing their sugar, if we're not still giving at least the, the insulin, they can actually get into hyperglycemia, a severe elevation with hyperglycemia. So I'm looking at the question where it says, can you go over the sick day plan, focus on type 1, that's on the group worksheet. So the sick day plan is kind of what I was alluding to right now. So your patients, particularly type 1s, but it can happen with type 2s, we worry about their sugar getting too high, again, because the body is under stress. So the glycogen is going to be broken down into glucose to get into the bloodstream to provide that source of energy for the cells. So for your type 1 diabetic, they are not producing any type of insulin. So the liver is kicking out all this glucose and there's no insulin to take it into the cell. So with your type 1 diabetics, when we talk about a sick day plan, it's very important that when they are sick, they continue to test their blood sugar. Typically, we say at least every 4 hours. It may even need to be done more frequently, and they should continue taking their insulin, okay? They might not be able to eat, but we definitely want them drinking. We want them to stay hydrated, and we can put some glucose into them through the drinks, okay? But very important, when they are sick, they want to test their blood sugar frequently, at least every 4 hours. They want to make sure they're staying hydrated with fluids that do contain some glucose, and they want to make sure that they're continuing to take their insulin. For your type 1s, they will also have them test their urine for ketones. Usually they're going to do that at least every 8 hours. Okay. But that's really, really important because you want to make sure that their blood sugar does not get too high and they go into what we call diabetic ketoacidosis. Because in your type 1s, when your blood sugar is really high, there's tons of glucose in the blood, but again, there's not insulin to take it into the cell to be worked on, okay, to take it into the cell so it can start working. And then when their blood sugar gets that high, that's great, but there's no glucose in the cells. So that's when they start switching to fat metabolism. Okay, they're not burning glucose anymore for fuel. They're now going to burn fat to make ATP. And that's where you have the ketones with the byproducts. So that's why your type 1 diabetics on those sick days, they will have them test their urine for ketones, because if they're spilling ketones in their urine, then they don't have enough insulin in their system because their cells are having to use fat instead of the glucose. Let me take a look here. Case study, it was prescribed carbs and protein because it was more than an hour away from the meal. Yes. How do you determine to give the carbs and protein or not? The reason we talk about the carbs, remember, carbs are going to be rapid acting. When I eat a carb, it's going to get digested. It's going to, raise my blood sugar fairly quickly. And that's why we give those in 15-gram increments. But like anything else, what goes up must come down. So the carbs will get it up, but it won't necessarily sustain that. So the protein, the idea is for the blood glucose to raise up, but to stay up at a certain level for a longer period of time before it drops again. So typically the recommendation is, if you're treating somebody for hypoglycemia, if their next meal is more than an hour away, you definitely want to use a protein along with the carbs. Yeah, so I see Brian talked about D50. D50 is a short-acting carb. That is something that's given IV, so we're going directly into the bloodstream. It's going to start working very quickly. Let me see. My patient's blood sugar was 211 after giving it, so I didn't give additional carbs and protein. And I lost points for it in the sim. Well, I don't know about that. I have to go back and look at your log there. Let me see. Yeah, D50, again, if you think about D50 that's administered IV or the glucagon that's administered IM, those are going to work more quickly than your oral carbs. Okay, so that D50, if you're giving an entire amp of D50, it's going to raise their sugar pretty good. The other thing is, it depended in the simulation how quickly you gave the D50. Okay, if the first time you checked the blood sugar and it was 61 and you gave the D50 right then and there, it's going to raise it much higher. Depending on how quickly you responded, if it kind of went a little bit and you gave the D50 when he was at like 41, you're going to see an increase, but it's not going to be as high. So I think the person that was talking about, the patient's blood sugar was 211 after the D50, not given the additional carbs and protein. If that was the case, I wouldn't necessarily give the additional carbs. I would look at a protein at that point, depending on how long it was going to be till they ate, because I want to sustain that blood sugar up a little bit so they're not dropping again. Let's see. How long will it take the oral carbs and protein to start working in a patient? It depends on what type of carbs we're taking a look at. Typically, when we're treating somebody, I like to give juice, 4 ounces of apple juice. We used to use orange juice, but orange juice is very high in potassium. And if your diabetic patient also has a history of chronic kidney disease, we want to be very careful that we don't raise their potassium level too high. So years ago, when I was in nursing school, our go-to, if somebody had low sugar, was to give them 4 ounces of orange juice. We've kind of switched that, looking at 4 ounces of apple juice, cranberry juice, or grape juice versus the orange, simply because of the potassium levels. So obviously something that's liquid that you get down them, that's going to be absorbed much more quickly than if you have a solid, something that's a carb that needs to be broken down in the stomach, small intestine before it gets absorbed. So that's why we tend to say liquids. The other thing too, like the glucose tablets that they have that you can take, those are also chewable. So we want them to chew that up because that's going to break it down, get absorbed much more quickly. The protein itself, going back to the how long will it take the oral carbs and the protein to start working in a patient, the protein is not going to raise the blood sugar right away. That's more to sustain the blood sugar. So I would not want to treat a low blood sugar with just protein alone. Okay, the protein needs to be given in conjunction with the carb. It's not going to raise it up right away. It's more to sustain that so they don't have a rapid drop. Let's see here. I'm just looking at your questions over here. These are really good questions. Are there any complications that can arise while in hypoglycemia like there are in hyperglycemia? Well, hypoglycemia, the bottom line is if your blood sugar is that low, you don't have the glucose to do cellular metabolism. So that's why you get the symptoms of hypoglycemia. The cells are just not functioning at the capacity they should be. And really at that point, when they get unresponsive, if we don't deal with it, they're going into a coma and they're going to die. I mean, they're going to die. And that's why we talk about, while neither one of them are a good thing, if I have to deal with it, I have to deal with hypoglycemia first because that's going to be the most immediate threat to my patient. That is going to kill the patient first, okay? Let's see, are you gonna go over the answers to the quizzes? Yes, I can. Let me see here. You know what, I have the answers to the quizzes, but I don't have the quizzes in front of me, so hold on just 1 minute. I don't think I'm sharing my screen. If I'm sharing my screen, somebody please tell me. Okay, let me try to pull these up here. Am I sharing my screen? Can anybody see that? No? Okay. All right, so let me get in here. I'm like one of those people that has so many tabs open that I can't even, you know, imagine what I'm doing here. Okay, so. Okay, good. Nobody can see my screen. Now we're in good shape. Okay, so looking at Unit 4, Quiz 3, hypoglycemia, the definition of that was well, I can't even say the letter because I'm not sure of how it scrambled it on Plato, but hypoglycemia is decreased blood glucose. Typically, we're going to say that it's less than 70 milligrams per deciliter. That's pretty much a textbook definition. Hyperglycemic hyperosmolar syndrome. That is the severe metabolic complication of type 2 diabetes. And I just want to differentiate that between that and DKA for a moment, because DKA, you can have DKA in type 2 diabetes, but it's more associated with type 1. With type 2, because the pancreas is still producing some insulin, in many cases, the cells never get to the point where they go into a complete metabolic acidosis, okay? You don't have the ketones that are associated with diabetic ketoacidosis. So that's why your HHNKS is associated with type 2 diabetes and your DKA is associated with type 1. Glycosuria is just simply presence of glucose in the urine. Postprandial is a glucose sample tested 2 hours post-meal. And when we talk about 2 hours, that's 2 hours after the time they begin eating, okay, that they begin eating. So it's testing afterwards. Polyphagia is excessive hunger. Retinopathy is the eye damage that results from diabetes. A fasting glucose. Fasting is a glucose sample after being NPO for at least 8 hours. Okay, that 8 hours is the key there. And the glycosylated hemoglobin, that is our serum test that's going to evaluate the average glucose over the past 3 months. Okay. All right, any questions on that one so far? If not, I'm going to move on to the next quiz. Okay, so looking at the U4C4 quiz, the best way to evaluate client teaching of self-administering a new insulin pen is return demonstration. That is true. Anytime you are teaching a psychomotor skill, whether it's a, you know, insulin administration, blood glucose checking, diabetic foot care, anything like that, the best way for you to evaluate, did the patient understand, did they get your teaching, can they do it, is that return demonstration. Number 2, clients with diabetes should have a professional eye exam at least every 2 years. That is false. It should be yearly. Diabetic client with a hemoglobin A1C of 6.8 is considered controlled. That is true. Our goal for A1C for our diabetic patients is going to be less than 7. Headache, irritability, and shaking are common signs of hypoglycemia. That is true. Diabetic clients can safely use heating pads on their feet as long as there is a barrier between the skin and the pad, the temperature is on the lowest setting, and the heat is applied for no more than 5 to 10 minutes. That is false. These patients are absolutely advised against using any type of heating pad because of the neuropathy, that it could be very warm and they may not even know it. And they're at higher risk for damage because of the poor circulation. So these patients should not be using any type of heating pads whatsoever. And that's why I said that little tip of using the hair dryer, it has to be on cool setting. It absolutely must be on cool setting because it could be too hot for them and they do not even realize it. Diabetics should wash, dry, and inspect their feet daily, along with thoroughly applying lotion to the entire foot. That is false. I do want lotion, but I do not want that lotion in between the toes. That is a key point. When checking blood glucose levels, failure to allow the alcohol to dry prior to obtaining the sample may result in an inaccurate reading. That is true. Which diagnostic test is most sensitive for detecting renal damage in a client with diabetes? That's going to be your GFR, your glomerular filtration rate. Okay. BUN and creatinine can tell us a little bit about the renal damage, but to really quantify how much damage is there, you're going to use your GFR. Which site is appropriate for administration of subcutaneous regular insulin? Left upper arm was the correct answer. Left deltoid is IM. We would not give it there. The right forearm is where we would give a PPD or an intradermal injection. And the right vastus lateralis, again, is an IM, and insulin needs to be given sub-Q. And the last one, which instruction should be included when providing teaching to a newly diagnosed diabetic client? And this has to do with their testing supplies. The correct answer was used needles and lancets can be stored in an empty bleach container. The principles of this are going to be, they need to be in a puncture resistant container. So some places you can actually go and actually buy a portable sharps container, depending on how often they're testing, what medications they're giving, those can fill up rather quickly. So they can use an empty bleach container. You want something that's going to have a very thick plastic, puncture resistant. The other options that were not correct was referred to reusing your own needles. That is not recommended. I will tell you that some patients do that because of the cost factor, but it is not recommended because when they reuse needles, they have old insulin that's inside of them, little remnants of it, and those needles have already been in the skin and are contaminated with bacteria. So that is not recommended. You would never recap your needle and dispose in a regular garbage can. That's just a sharp hazard. And you certainly wouldn't store them in a Ziploc bag. Some providers will give some guidance on how patients can dispose of them. What I generally recommend is that diabetic patients should contact their trash hauler and ask how they would like those to be discarded. A lot of your trash haulers, as long as they're in a puncture resistant container and they're sealed, they usually have you put them out with the regular trash, which just totally goes against anything we would do in the hospital. You know, it really depends on the trash hauler, but the key piece is that it needs to be in a puncture resistant container. Okay. Other questions for the good of the order? You can type in your chat boxes if you have anything else. No, I did that good, right? Not good. Okay. Are you reusing a needle with insulin pens? Very, very good question. Are you reusing the needle with insulin pens? No, we generally do not. The insulin pens usually have the individual screw-on needles that are used, that are applied each time they're using it. And that's also why you generally need to prime your insulin pen with 2 units of the insulin before you actually dial up the dose. Let's see here. Ask, is the study guide due? Oh, that study guide, actually for this, it's really not due. It was more to kind of help guide you through the content, especially because we were going from 2 days down to 1 day. So this particular study guide is not due. It was meant to help you. When we get to Unit 5, there are going to be online class worksheets that go along with each class, and those will be due, but this particular one is not. I do have a question on CP2. I think what I'll do is start a totally different Zoom and chat for CP2. That way, for students that doesn't apply to, I'm not holding them up and prolonging this particular Zoom. So I can do a separate Zoom chat for CP2. Other questions related to diabetes? Oh. Okay. All right. Well, thank you all for joining me. Oh, wait, here I got one new message. Hold on. Oh, 2 new messages. Can you go over how, ketones affect diabetes? Okay. So ketones affect diabetes. Ketones are basically just a byproduct of the cells burning fat instead of burning glucose. So what that basically means for a patient with diabetes, because they, particularly type 1s, because they don't have insulin being produced in the pancreas, that insulin isn't there to take the glucose into the cell for the cell to be able to use it to make ATP. So because it doesn't have glucose, the cell is going to burn fat to make ATP. And as a byproduct of that fat metabolism, you get ketones. Your body gets rid of those ketones by processing them through the kidneys, and that you essentially pee them out, which is why your patients with type 1 diabetes on those sick days, we are, they want to check their urine for ketones every 8 hours. Because if they are spilling ketones in their urine, that tells us that the cells are burning fat, not glucose, and they need some insulin to be able to pull that glucose into the cell. So I'm hoping I addressed that. You starting the CP2 Zoom right after that? Sure, I can do that. Possible to go over alternate experience, same day assignments briefly. Okay, let me skip down to the next question. So why does that not happen with HHNKS? I think you're talking about where I was talking about the ketones before. The reason you don't see the ketones with HHNKS is because with type 2 diabetes, you still have some level of insulin production in the pancreas. Now, it's not enough, but it is enough to be able to get the glucose into the cell. So there's minimal levels of glucose getting into the cell, but it's enough to give the cell at least a basic amount of glucose for them to make a minimal amount of ATP. So those cells never completely switch over to fat metabolism, which is why you don't see the ketones. You don't generally see the severe acidosis with HHNKS that you would see with DKA. When does a pancreas transplant become an option? That is one of the newer treatments. It's not very mainstream, and typically they're not just going to transplant a pancreas. Usually that would be somebody who requires a multi-organ transplant. Usually they'll transplant the pancreas and the liver together, depending on the situation. Usually we see that more with like patients with cystic fibrosis, not so much just your diabetes, your type 1, type 2. Okay, is it possible to go over the alternate clinical same-day experiences assignments briefly? I'm actually going to turf that one to Mrs. Morrison. She was the one that created those particular assignments. And even if you are with Mrs. Harbaugh for same-day services clinical, I believe Mrs. Morrison is available by email tomorrow, and you can even set up Skype with her to kind of go over some of that stuff. I will contact her and ask her if she can kind of put up a little video thing that kind of goes over the expectations. But I'm going to turf that one to her since she created those. The goal for those same-day experiences, the same-day services ones, is really to focus on what would you need to do to be able to take care of the patient post-operatively, but also more to focus on the discharge teaching. What is the key pieces you need to teach related to that procedure, and then the actual video piece of you videoing yourself giving the discharge teaching. Can we get a test breakdown like before, please? Absolutely. That's on my list of things to do today. Yes, and there will be one dosage calculation question, and there will be a calculator on the screen. I would say approximately half of the exam is going to be diabetes. The other half is going to be GI, but I will give you a more specific breakdown than that. Oh, happy dance. Okay. All right. Other questions? Other questions? Okay. Okay, so I'll probably send out a little survey after this. I mean, obviously, oh, can you answer mine? Which one did I miss? Oh, are we going to need to know the MOA of all insulin's oral meds, or just the side effects, nursing implications? What I want you to kind of understand is how the oral meds work. You know, what are the things you're really going to be monitoring for with those? So things that are kind of generic across the board, we talked about the GI upset. Metformin, you definitely know about holding that for 48 hours post-contrast. Let me see here. The other ones that are very specific, like I think about the ones, Jardiance and that particular group, the ones that promote excretion of glucose through the urine. Obviously, if you have glucose in the urine, that's going to put your patient at higher risk for UTI. It might put them at higher risk for like yeast infections as well. So that's something very specific to that classification. That's kind of where I'm going with that, really kind of looking at, you know, thinking about giving those medications. Obviously, if they are not eating, you want to be very cautious in giving your oral medications, just simply because once it's down in their stomach and it starts dissolving, you have no control over it. And that's why in the hospital, when you have somebody come into the hospital and we put them on blood sugar checks and sliding scale insulin, we like to use Humalog or Novolog, the rapid acting insulin, because we know once we inject it, it's going to have a very quick onset, peak, and duration. So that allows us to have a little bit more control, and we can respond to it accordingly. Whereas if I give them Lantus, well, that's working for the next 24 plus hours, and I really have no control over that other than to, you know, give them glucose as needed. So Reagan, did that answer your question? The insulins, you're kind of like focusing more on basically the concepts of the onset, peak, and duration. You know, I'm not going to give Lantus insulin to cover my AM meal. Okay. Just kind of thinking about, you know, when would my client be at highest risk for a hypoglycemic episode? For the exam, can you make it so that it doesn't randomize the questions and have them grouped together? I think Plato just automatically randomizes them, but I will check into that, and I can put that in my test update. Either way, I'm not quite sure on that. Let me investigate that and get back to you on that one. Let me see here. For the NCLEX question, we all got wrong. The very first one in the packet under the megalipramide. Oh, yeah, that's right. So we talked about grapefruit juice, but yes, that particular class, in fact, if you have your packet with you, the classroom instruction packet that had all the meds in it, grapefruit juice is a concern, but you're right. Alcohol is also a concern, specifically with the sulfonylureas. And mainly, I have it in there that they also want to avoid alcohol because it can cause the flushing, the nausea, vomiting. It can actually cause palpitations. So that is a concern with the sulfonylureas. It really is dose dependent. So like if I take a sulfonylurea and I dose myself in the morning and I'm having a glass of wine tonight, I'm probably going to be okay with that. If I would take it at the same time, I'd probably have more of an issue. Grapefruit juice has to do more with the absorption. The alcohol more has to do with those symptoms. If it was a SATA question, I love that. So both would be considered correct in an NCLEX question. If it were a SATA, yes, absolutely. When I do my breakdown of the exam, I will also list the question types. The majority of them are going to be multiple choice. The dosage calculation is multiple choice. I have to count them. I want to say there's 3 or 4 SATA questions on there that select all that apply. But I will give you a specific breakdown with that. Other questions? Okay. I am going to send out a survey. I would appreciate if you would answer the survey just to kind of give me feedback on this Zoom. I have had the privilege of being a Zoom attendee. I have never actually been the Zoom host. So I'm hoping it went okay. I'm hoping today was at least helpful for you. My goal is to do a Zoom on every day we would have had class, just simply to keep you guys engaged with the content, but also to give you kind of a sense of normalcy in these very odd, uncharted waters. As I was Skyping with a couple students this morning for appointments, keep in mind that you need to take care of yourselves, and it's important to promote your mental health as well. This is a time where anxiety is kind of running rampant. So I do want you guys to take care of yourself. Reach out to me, reach out to counseling, reach out to your peers. We are in this together. I can't promise it's going to be completely smooth. There might be some bumps along the way as we're using the new technology. If you're having issues, let me know. If there's things that I can be doing to better help you, please let me know. I want to make this as painless as possible. It's not going to be completely painless, but you know, at a tolerable level. I just want to make sure, you know, just to try to keep it as stable for you guys as possible as we're all practicing social distancing. Another question, our internet is flaky. What happens if we lose connection during the exam? If you lose connection during the exam and you're not to there anymore, I want you to contact me, okay? Go ahead and you know, send me an email at that point and just let me know what happened. And then I'll get in touch with IT and we'll figure it out from there, okay? But I don't want anybody panicking. If something happens, we'll deal with it. You know, we will deal with it. Like I said, we're in uncharted waters and, you know, we'll muddle through it together, but we will get through it. This will pass, this will end, and we will be okay. Oh, another question. Let's see here. So any A1C level below 7 is good for diabetics. Yes, that is correct. Your diabetics, our goal is to keep them below 7% on their A1C. Should we be concerned grades will fall due to this? I'm not overly concerned on that at this point. I also know that I don't want to put the cart before the horse. So let's just take it one day at a time. We're taking this week. Looking at the quizzes, not everybody was done with the quiz before I popped on here at 12:15. But looking at the quizzes, the grades looked pretty good. I'm assuming all of you did your pre-class prep, so those are automatic points to kind of help that quiz grade. You know, that's something that you know, we'll kind of take it as it goes. I'm not overly concerned at that at this point, but it is something that I will keep on my radar and keep monitoring. Okay, some concerns about internet. Planning, at least for exams, if you have a place you can go to take the exam that's going to have a better internet connection, that is definitely ideal. I had heard, I do need to confirm this, but I had heard from administration that there was limited computer availability at the Penn College Library. It is closed to the public, but I believe They might be able to let people in with their ID, but let me find out about that, and I will post that in my announcement about the exam. Because if you have really sketchy internet, that might be a good option for you. Oh, here, somebody posted the library is still open with study rooms available. I do believe you need to contact the library if that's the case. I will confirm all this so they can actually reserve space for you. How will this affect SBON requirements, State Board of Nursing requirements? At this point, the State Board of Nursing has not changed any of the requirements. The RN program does not have by law a set number of hours that you have to have per se. What it does state in the regulations is that you must graduate from an approved program, and we are an approved program. Now, that being said, realistically, we're losing the hands-on portion of this part of the semester. So what that's going to mean for you is coming back, particularly in the fall, you want to get in there, particularly those first 2 weeks, and have some extra practice in the lab. It may be 5 months since you gave an injection. You need to practice that. Might be that long since you're giving meds, since you're using IVs, practicing on the pumps. Now, that being said, all of the courses are in the same boat. So when you get to 214 in the fall, your instructors do know that, and they're going to account for that. The same way I have to account for Mrs. Brenchley's students that'll be coming to me in the fall, knowing that they're not getting the last part of their lab. They're probably not going to check off on their IV skills. So I'm going to have to adjust for that in the fall. And that's something we'll work on together as a department. Rest assured, we will make sure that you get what you need to get you prepared for boards when you graduate next May. Okay, hold on. Let me see here. Let me scroll back up on the thing. And I'm just answering questions at this point, so you're welcome to stay on. But if you're like, oh my gosh, I don't want her to see that I'm leaving before the other thing, I'm totally okay. This is going to be it is recorded. It's going to be uploaded for access. So if you need to pop off of here, that's totally okay. Let me just go back and look at my thing here. Okay, for the quiz, I didn't choose the empty bleach container because I didn't think it was safe storage or out of reach of children. Can you go over that question again, please? Sure. So that particular one, I totally agree with you in the sense that if I'm using the bleach container, I do need to store it up away from children. That is an example of a question where you may not like any of the answers, okay? But of the answers that were presented, which one of them was going to be the safest piece, the safest option for disposal? And of the ones that were there, the bleach container, it is puncture resistant, you know, so it's going to help prevent those needle sticks. So that would be my rationale for that. You're really looking at, it's really true, the puncture resistant is what you're looking at, that it's going to be in there. It's not going to poke through like a Ziploc bag or a regular trash bag. Let me see here. Okay, does anybody, some questions about the library. I really don't know about those. I'm gonna refer you to the library's website. Will the Zoom video you're making about CP2 also be recorded and uploaded? Absolutely, absolutely, why not? It's all good. I'm here, I wanna try, like I said, I wanna try to make this as consistent and structured for you as possible, and not add any more anxiety and angst than you already have. You know, so we're in this together. I'm here to support you, and you know, we're going to get through this. We're absolutely going to get through this. Any last minute questions? If not, I'm going to end this meeting. Give me about 5 minutes, figure about 2 o'clock if you want to pop on for CP2. I will post a separate link on the Plato site because I don't think I can use the same link. I'm not quite sure. We'll figure that out. So. All right, for those of you I'll see in a couple minutes, great. For those of you that I won't, thanks for coming. And like I said, we're in this together. So take care.